the avian flu, using the 1918 Spanish flu epidemic as an example, and perfectly predicting long COVID in 2020. In that article, he said that there has been no influenza epidemic that has not been followed by neurological sequelae since the time of Hippocrates. So this is not novel. This is something we've been more prepared for, and we should be further into the research, except for we were also consumed by acute COVID and hospitalized patients that long COVID has been ignored up until now. And I think that we don't need to look further than this recent revelations about multiple sclerosis stemming from Epstein-Barr and other neurodegenerative diseases, Parkinson's, Alzheimer's, having viral roots. Unlike AIDS, which was a syndrome looking for a virus, we have a virus looking for a syndrome. We know what the cause is. And I want to give you some examples of what our members are experiencing. We have over 200,000 members, and it's interesting to hear everyone talk about anxiety, and the first thing when you talk about long COVID and you have any expert come in, they will talk about anxiety and brain fog. Brain fog, which should, by the way, be called, which should be called cognitive dysfunction. Brain fog makes it sound like a hangover. Let me give you some examples of what people are going through. This is not, these are beyond psychosocial kinds of things. We are talking about extreme neuropathic pain that mimics advanced diabetes. We are seeing Parkinsonian-like tremors, feelings of inner vibrations that are keeping people awake at night, whether or not it's akathisia or something similar, we don't know. We are seeing COVID-onset diabetes. We are seeing COVID-onset lupus. We are seeing adrenal fatigue. We are seeing hearing loss, vision loss, loss of teeth. Dentistry is a huge, huge piece of long COVID and needs to be addressed because the dental divide in America, as in New York and just like the rest of the country, is deep, and people are losing teeth due to vascular damage to the jaw. When Dr. Martello spoke about children with bleeding hands from OCD, let's also consider the fact that children are getting COVID and are having neurological reactions. And so the first suggestion should not be that they are so nervous about hand washing. No one's spoken about hand washing since spring of 2020, now that we know it's an aerosolized virus. But what if those children actually had COVID and are experiencing neurological and psychiatric sequelae? And that needs to be considered when we're talking about psychiatric issues in adolescents and young and children. So when we're talking about long COVID, I want you to think about our members who are in their early 30s, who were athletes, who were, marathon runners at the height of their career, who are now in wheelchairs. They are on permanent feeding tubes. They are disabled. They might have their lives, but their livelihoods have been ripped from them. And so this is more than just fatigue. This is more than just anxiety. These are lives that are ruined. And as a result, we are getting suicide threats daily. We have had many members actually take their own lives. So that is what we're talking about here, and that's not from depression. That's from having no hope for the future because their symptoms are so ravaging. When we talk about, Dr. Martello asked before about asymptomatic cases, when we looked into what the one symptom was that was most predictive of long COVID, was it having a cough? Was it having a fever? It was being asymptomatic. So you have to remember that most of these people were not hospitalized. They had what are considered mild cases of COVID or asymptomatic cases, and they are largely the healthiest among us. One of the theories being that it's an unregulated over-response of the immune system. And who has the most robust immune system? Someone just like me. Is the average long hauler a 46-year-old woman? I was 46-year-old woman when I got 45, I guess, when I got COVID. And so if you are worried about the economy, then you worried about long COVID because these are people who cannot return to work, they cannot take care of their families, and they are suffering and they are running out of hope. When we talk about these waves, when we talk about the numbers and who's hospitalized and, vis-a-vis vaccines, et cetera, waves don't count when it comes to long COVID because this has been going on since winter of 2020, and according to the CDC, it's not 1 in 10, it's 1 in 3 people who develop long COVID. They've said 1 in 10 children, but that is probably a vast undercount considering that the youngest children have not been vaccinated and toddlers and babies cannot express when something is wrong with them. I will go quickly through a few policy recommendations. One, vis-a-vis this suicide threat that we are seeing a coming threat of a tsunami of suicides. We need a dedicated suicide hotline for long haulers. We need a registry. We need longitudinal tracking of COVID patients so that we have the earliest signal if, God forbid, in 10 years we have a rash of 30-year-olds who are presenting with early onset, dementia. That is a possibility, and we need to have the first possible sign. There is no national registry, but New York could set one up. I know that Senator Hoylman had introduced legislation, which we advised on, but we need research. I sit on the NIH's Recover Committee, the $1.15 billion that was entrusted to the NIH last February, which is going into a 4-year-long data accumulation process. It's just a data project. There is no hope of therapeutics or treatments within that $1.15 billion, which is not only wasting taxpayer money, is putting a stranglehold on all other COVID research going on in America. So whereas we want to trial hyperimmune globulin and monoclonal antibodies as treatments, there's no money for this because if New York talk about putting your money where your mouth is, we need money for research because people are dying, and we have people dying after COVID. They are not counted as COVID deaths. Are they counted as long COVID deaths? No, we didn't even have an ICD code until the end of October. And I'm not sure that anyone is actually even using it yet. As far as post-COVID care centers go, I went through Mount Sinai. And Survivor Corps has our website. It is www.survivorcorps.com. It is an incredible repository of information. In fact, it has the only existing national map of every post-COVID care center in the country. That does not mean they are all built equally. Anyone can put a shingle out and call themselves a post-COVID care center. There needs to be oversight in this. And the fact is that they are never going to be able to accommodate the number of people who are suffering from long COVID. Pre-Omicron, we had statisticians saying that we had 150 million infections. That means 50 million cases of long COVID, and that was before Omicron. And so, how are we ever going to get all of those people through long COVID care centers when you think about equity issues, when you think about the fact that so much of New York State is rural and there's not physical proximity to these places? If you didn't have a positive test, you cannot get in. Despite we got the CDC to change its guidance last June and say that you no longer needed a positive PCR or antibody test to get into a long COVID care center. But that is not guidance that is being followed because these centers are overwhelmed. The wait times are over a year, and they are only there for the people who really pushed themselves in and got that original testing, which most people were denied. And not only that, we are creating a new class of an underrepresented class by having people doing home tests and not being able to register their results. So if you don't have a follow-up PCR test, how are you ever going to prove that you had long COVID? We need an easy, well-publicized hotline that you can call, or a website where you can report your home test, because these people will never get the care that they deserve. And so I believe that post-COVID care centers should be models of excellence, where that research is then brought to communities. It's brought to ambulatory settings. It's there for patients. It's there for providers, where we have hotlines, where we have continuing medical education, and we can distribute that That is a fool's errand. We've spent 2 years looking at definitions. The CDC's come up with theirs. The WHO has come up with theirs. The NIH is spending 4 years looking at definitions. We need treatments and therapeutics, and we need to